I'd like to kind of extend my gratitude to all of you for actually showing up and being here. It shows me that you guys are engaged respiratory therapists and that you're interested in what we have to say, and I'm interested in learning from all of you as well. And I want to extend my gratitude to Draeger Medical for putting this conference on and allowing us the opportunity to have these discussions, because I think it's very difficult to be able to get good speakers in a place like Ryan and Natalie and be able to learn from them without industry support. It's difficult to be able to do that today in today's climate where everybody's trying to save a few bucks here and there. And so we thank you very much, Draeger, for allowing us this amazing opportunity and for having discussions about lung protection and volume-targeted ventilation, and later we'll talk a little bit about non-invasive ventilation. So Ryan kind of he had a good primer for building up to ventilation and how to understand when your baby's trying to tell you something with regard to airway graphics and analysis of waveforms. That's not just a bunch of abstract art that you're seeing day to day when you walk in there and you're taking care of your patient. It's real pretty, but it means something. And if we're aware of what's going on with our patient, then we can make modes like this work. And so we're going to talk a little bit about volume-targeted ventilation, and I will talk a little bit about the journey that we've been on at Seattle Children's Hospital. I'm not saying this is going to work for everybody, but I do know that part of the reason why we bought the ventilators we did was because it did volume guarantee well. And we tried many, many ventilators, and before, we weren't able to really get them to perform very well. And so for us, we finally got a ventilator that could do it well, and we went into the units, and rather than placing kids on VG only to have night shift folks come along or some other physician from somewhere else and switch it out of volume guarantee and put it into pressure control, we developed guidelines. And those clinical guidelines were very instrumental in allowing us to focus and not switch the kids out of pressure control. And so it took a lot of work, and that's why I have a receding hairline, and I am starting to get gray hair, and I've got a few ulcers and whatnot. It's because you have to have a physician champion, you have to have a respiratory therapist, super users, you have to have champions in order to make something like this work. It's not like you just pull it out of the air and say, oh wow, let's do volume guarantee today. You have to know exactly how that mode's going to behave for the specific ventilator that you're using. You have to realize how to mitigate some social problems that may arise and the fact that you're trying to change the culture based on evidence. Natalie spoke to that very well earlier. If we don't have the evidence, then we have nothing at all, right? So there's now evidence to support doing a lot of this. So we'll touch on that a little bit, and we'll talk about kind of what our journey looked like and focus on management guidelines, but first kind of build a compelling argument with reasons as to why we all should be doing volume-targeted ventilation. And that's why the title of this talk is Volume-Targeted Ventilation, Feeling Pressured to Make the Change. Do you all feel pressured to make that change? How many of you have made the change already and you're doing volume-targeted ventilation? Okay. How many of you are talking about it right now and you're interested in actually doing it? A few of you? And how many of you don't even ventilate your kids in the NICU? That's what we really should be talking about, right? So that leads me to the point that when it comes to invasive mechanical ventilation, we are doing it less frequently as respiratory therapists. It could one day become a lost art, especially in the preterm babies. I mean, I'm working on aerosolized surfactant right now with Aerogen Pharma. It's a little vibrating mesh nebulizer. It's breath actuated. We found a way to integrate it into nasal prongs. Why do preemies get intubated? Well, because they fail CPAP because they need surfactant, right? And so maybe one day that will be the case, but for now, as respiratory therapists, we really have to be in tune on how we manage these babies and how we protect their lungs. There's a lot of data out there. I do want to mention that I have received funding from Draeger for speaking and for research purposes. And we have some intellectual property related to a neonatal non-invasive respiratory support device. I work with leading companies like Vero Biopharma, Aerogen Pharma, Benel, Vapotherm, so a number of different companies that have provided me with research in order to do this. Research funding in order to do this here. And so as a respiratory therapist, we have unique jobs in that we really knew how to schmooze early on. And we lived an uncommon life, and we tried to aim to get extraordinary results. And we basically realized early on with some of my mentors that you don't have to be a doctor or a PhD to do research. You just have to be able to throw really good cocktail parties. You have to be able to, talk a little smack. You got to make some stuff up here and there. But you also have to prove that you can publish papers and you can do the work, right? Natalie spoke to that earlier. But then you got to get buy-in from people, and then you got to present at national conferences, and then you got to go to China and India and all these other places. and show that you're able to do your research, and then the money will follow. So in the true culture of, grassroots research, we have actually built a number of labs at my institution, and I manage these laboratories. It's a translational research project, which means we take questions from the bedside, we bring them back to the bench, and then we bring those questions back to the bedside, test them again, and then we present, hopefully get things published, and then we take it to the bedside, and that becomes the new management strategy for babies. So whether it's aerosolized surfactant or some new mode of ventilation, we will test it. And we will take the money, and we will hire respiratory therapists to do the work. We don't fund physicians. I get some physicians that actually come from out of other countries and they want to work in my lab, but it's all respiratory therapists that work in our research lab. We've done anything from look at the ROM cannula inside and out to looking at different aerosol delivery devices using, different people come from different institutions with questions and money. And if they don't have the money, then I get some seed funds to do the research, and then that only brings in more money. And so we've done a lot with characterizing particle size for different nebulizers and so on and so forth. But then we have a pretty active animal laboratory as well, where some pulmonary physiology friends of mine taught me how to induce surfactant deficiency with rabbits and create a respiratory distress type model that's spontaneously breathing. And so we've done a lot of work with that. And we also have piglets as well in my laboratory. So we're pretty busy overall. And when we're not dealing with the whole, looking at different medications and looking at volume-targeted ventilation or some other ventilation strategy in the animal laboratory, then obviously we're in the units doing research. And so we have a number of different approved studies in the clinical setting as well. So we keep pretty busy. We try not to do much of this right here, but there's some questions that need to be answered, and that involves using some animals for our research. So today we're going to talk about the objectives of this study is we're going to talk about ventilator-induced lung injury. What does it look like? What does it look like? What does ventilator-induced lung injury look like? Well, that's difficult because you can't see through the chest wall of an infant, right? But you can evaluate how many days they've been on a ventilator and how much oxygen they require and how much ventilation they require. And you can also look at an X-ray and be able to determine what type of physiologic changes may be going on. But more importantly, I think aside from recognizing ventilator-induced lung injury, we have to understand how we can prevent it as respiratory therapists. And we need to understand how to prevent it as physicians. And as a team, we need to collaborate and try to find ways to mitigate injury and inflammation, because we know that the ventilator, especially in preterm babies, is very, very instrumental in causing lung injury and inflammation and putting them at risk for chronic lung disease. We see this a lot, right? How many of you see chronic lung disease in your units? And we're seeing it more and more nowadays because we're saving babies earlier. And so we have to try to figure out a way to be able to support these babies better. And so I think, as I mentioned before, the best mode of ventilation really is AMV, or without mechanical ventilation. That's what I try to tell people. And so we'll talk more about non-invasive ventilation a little bit later. But for now, we'll kind of talk about the different benefits, not including high-frequency oscillatory ventilation or jet ventilation, but just conventional ventilation, how we get to use that ventilator better to be able to provide better lung support and less injury. And so we'll talk about volume-targeted modes. We'll talk about the limitations, because I think that's the biggest thing that makes it so that you guys are just like, forget this, I'm done with it. This kid's got runaway PIP, and they're on CPAP, and what do? Oh, I put them into pressure control, and I walk away. That's what we're not going to do. And we're going to talk about kind of different ways that we can troubleshoot the mode that you're using. We'll talk about different modes and how they perform. And then we'll talk about the guidelines that we use to support, as Natalie mentioned before, 80% is that 80-20 rule. We can support approximately 90% of all of our patients in the NICU with volume-targeted ventilation. And we have a NICU that has 4 22-weekers in it right now, all the way up to big babies with MECASP and CDH, and you know the business. So we got a lot of surgical kids as well with huge distended abdomens. So we've tried to find ways to navigate the best use of this mode of mechanical ventilation. And so pressure control ventilation has been the backbone of neonatology for 40 years. As long as I've been alive, babies were supported with time cycle pressure limited ventilators. Many of you still probably use pressure control, but the only real difference between the modes of the past and the modes of the future is that you now have flow control valves that are very reactive to patients' inspiratory efforts. So you don't have to constantly adjust the flow in order to provide appropriate pressures for that patient. Ryan touched on that a lot earlier, like how do you get a perfect pressure waveform? Well, you got to increase the flow. The ventilator does that for you now. But it also allows the baby to trigger their breaths on their own using proximal flow sensors or flow sensors located back at the ventilator. And we know that these ventilators, actually, the improvements are drastically better than the ventilators of the past, right? But if you look on paper and you look at patient-triggered ventilation versus non-patient-triggered ventilation, and you look at the meta-analyses related to this, it shows no difference out of thousands of babies that were supported with both modes of ventilation. There's no difference in outcomes. And really, we probably think that there may be, but you got to keep in mind as well that in the early use of IMV that was non-patient synchronized, they would typically use a lot of sedation, a lot of paralytics to be able to make them look good. You remember this, you know? And, you know, we'd have to, there was no leak algorithms like all the, you know, us, the younger folks are using nowadays. I'm somewhere in between, you know, I just look young. But I can say that these leak compensation algorithms and the volume targeting and the proximal flow sensor use, it definitely has made a difference. We barely sedate or paralyze our kids anymore. And so, especially in like some of these BPD kids that are very difficult to manage. So we always had to rely on our intuition, and our clinical focus was to look at the patient, listen to the breath sounds, get blood gases, blood gases, blood gases, blood gas, till we practically exsanguinate the patient. Well, that's changed now, and I think that we've really come a long way from having babies basically tell us, hey, my lungs are, I've got excessive tidal volume based on high airflow through the lungs. You know, I need more PEEP, which in that case, back then, we didn't even use PEEP. I remember the day of using the Seacrest ventilators in 1995 when I first started. And a couple of the nurses nicknamed him Seachrist. I'm like, why do you call that a Seachrist? It's spelled Seacrest. And they're like, because it seems like every kid that we put them on, they end up seeing Christ at some point because we don't have any way to monitor or limit tidal volumes. And at the time, they didn't realize it, you know. And so every baby was kept on a ventilator for about a month if they were preemie. If you were less than, you know, if you were around 32 weeks, they were kept on the ventilator until you were 1 kilo. But we didn't understand the implications of lung injury and inflammation. We didn't realize that high FiO2, because we weren't using sufficient PEEP, was going to wreck the lungs and cause oxidative stress in the lung. You know, and that stress, that lung injury is almost as bad as excessive tidal volumes or not using enough PEEP. So I think it's important to kind of realize that we have come a long way. And I can't operate this remote, but I can. And so, speaking about complexity of new devices, have you ever heard the saying, once technology's master, we reach disaster faster, right? These ventilators are better at performing, especially when it comes to babies with these tiny, tiny lungs, thumb-sized lungs, right? They can sense a respiratory, they can give a tidal volume that's 2 mLs within a 10% accuracy. So I think, you know, that because the ventilators have gotten so complex, then we have a few software glitches here and there, or maybe we have one power down in the unit, but it's very infrequent that that happens. And for the most part, these ventilators do exactly what we think they're going to do. However, we have more things to monitor patients nowadays than we ever did before. So we have graphics, we have chest x-rays that pop up right there at the bedside. We didn't have that before. We used to hold them up to a light. You know, I still do that when I go to China and India. It's so nostalgic. And you know, we've got proximal flow sensors at the airway, which allow us to trigger and to monitor graphics. So now we can trust our airway graphics, whereas before, they were back at a ventilator. There's compressible volume loss in circuits, and that compliance, when it is higher than that of the baby's lungs, then you don't know what you're looking at. But furthermore, you don't know what tidal volume you're getting. So now that we know what the tidal volume delivery is, then maybe we can send a signal to the ventilator to say, hey, you know, the volume's getting small. And then you can come in and turn up the pressure if you use pressure control. Or we could do something different. So we'll highlight that. So pressure control ventilation, again, life-saving mode of ventilation, but has several limitations. Airway pressure is constant. So your tidal volume, or your compliance and your resistance and your patient effort are all going to change that tidal volume. Okay, so if that pressure is constant and your resistance goes up and your compliance goes down, then less volume is delivered to the kid. Or if they're taking big breaths in, you know, before they didn't get the flow that they probably needed. Now they can, because there's flow control valves. Anyway, it's difficult to achieve a consistent tidal volume. And what we know now, and it's unfortunate that people have to do animal studies, you know, it's not cool. Hopefully most of those animals survive, but what we know now about lung injury has to do with animal studies. It has to do with identifying injury at excessive volumes versus small volumes. We will never, ever again do an ARDSNet type study in babies. okay, because we showed that the mortality rate was higher with 12 mLs per kilo versus 6 mLs per kilo in patients with ARDS. Everything else after that, which brought us to the point that we are using 4 to 6 or 5 to 7, whatever your tidal volume goal is for babies, that dosage is based on these animal studies. And that has made a huge difference, I think, in the outcome and the mortality of some of these babies. And so we know that this excessive tidal volume is a risk. It's called volutrauma, right? We call it volutrauma. But we also know that if you ventilate at too low of an inspiratory pressure, or too small of a tidal volume, that can be almost as injurious to the lung as excessive tidal volume. And that shear injury of the airways sticking together and then opening up 30,000 times a day, you can do the math, or Ryan can do it for you, he's good at math. That's a rate of 60, right? You can check me on this later. But a rate of 60 is approximately 30,000 times a day. And most of the babies that we support now, a high number of them, are babies that should still be in utero experiencing pressures from the amniotic fluid of around 3 to 5 centimeters, right? And so, of water. And so if we cycle that lung, that makes a big difference, you know? And we'll talk about lung injury under a microscope here in a minute, because I think that it's compelling that you get a good look at that. We do know that if you wean that pressure, then the lung injury is less likely to occur. And we called this barotrauma for years and years and years because we never knew how to measure the tidal volume accurately. How many of you actually measure tidal volume right now with a proximal flow sensor? How many of you measure it back at the ventilator? Or maybe you do both. Okay, flow sensors back at the distal, at the ventilator. Now, how many of you take the tidal volume and you look at the inspiratory tidal volume? How many of you look at expiratory tidal volume? You look at both. Nice, I like that. We're going to have fun today. And then how many of you divide that by the body weight and you look at the volume as a dosage? Okay, good. That's awesome. But that's going to be mandatory now, right? And so, because volumes should be a dosage. Just like morphine, you give too much, that's not cool, right? If you give too little, your patient's in pain. Well, if you give too much volume or not enough, then you are injuring the lung. And that's why it should be ordered as such, as a dosage. And as a range, 5 to 7 mLs. Or 4 to 6. We'll talk about tidal volume and the whole conundrum behind tidal volume and how we got to that in babies. So I'm going to start with a case. You've all seen this. If you've been working in neonatology or respiratory neonatal medicine, you've seen this before. It's the garden variety, 27-week preemie that comes in, 850 grams, got brought in via transport to our institution. And at this time, we had the Avia ventilators. We were super psyched because we had proximal flow sensors. So you could sense the flow there, but you could measure the tidal volume, which was extracted from the flow signal, but also trigger the ventilator. So the kids look good. And then look at the x-ray. Okay, something's going on, obviously. And there appears to be some refractory hypoxemia because we're on FiO2 at 80. Is this baby being injured right now? That's oxidative stress, right? So we're going to keep them on 80 for a while? Or are we going to turn the PEEP up? Okay, so you could go up on your PEEP, and I'm not afraid to go up on PEEP. I just got back from China, and all the babies were on 3 to 5. And there were kids on 80, 90%, and I literally had to blindfold them. And I said, trust me on this. You think we're PEEPophobic, and it has taken years for us to not be, right? Because we always had an oscillator. And why did they look so much better? Because we used a higher mean airway pressure, right? And you can do that with a ventilator, and it's probably not as injurious as an oscillator. I'm just saying, these oscillators do not control volume yet, but that may come someday, where you actually servo-regulate the delta P based on a tidal volume measurement. They've got it in Canada, they've got it in Europe, but we don't have it here. And so, you're not protecting the lung with the oscillator, but you're improving gas exchange, and then so now you can go back to the department and just chill because their PO2 is 150, and the nurse is weaning the FiO2 for you, right? We're injuring the lung here because if you were to look at this under a CT scan, which we're gonna here in a minute, this wouldn't look like diffuse bilateral infiltrate, right? Because this kid has 6 mLs per kilo going in. But if we look at the different kind of heterogeneous lung recruitment and the collapse that goes on in the lung, if you set that at 6 mLs per kilo, we're running a risk that the majority of the ventilation is now going to the healthy lung units, and if we're not using enough PEEP to open the airways at end exhalation, then we may open them briefly, but then they're going to collapse, right? So all that volume goes to the area of least resistance, and so we're not necessarily protecting this lung at all. So I think maybe if you look at the airway waveform, the pressure volume loop, we see here on this pressure axis and on the volume axis, it's requiring a lot of pressure in order to move a little bit of gas in the lung. That means something. It's like when you take a balloon or whatever and you blow into it and it requires a lot of pressure, and then finally you get to the point where it opens up, that critical opening pressure, right? Only to snap back down. But if you stretch it out or you put a little bit of end expiratory pressure, it's easier to open it. And so the lung responds to that favorably. And so if you can do that with CPAP, great. But if you have to go on a ventilator because they have respiratory failure, then we have to try to protect that lung. So in this kid, we gave surfactant. And the RT went down the street and picked up some sushi, brought it back, and got a call. And he said, what the heck? You know, and the nurse is like, well, I want you to come up here and just take a look at this kid. It looks like he has excessive chest rise. His lung sounds are wonderful. And you know, his heart rate, you know, it's kind of going down every once in a while. But the blood gases are what I'm kind of interested in because they look awesome. You know, these blood gases look amazing. And the RT goes up there and he says, yeah, you're right. Let's turn down the blood gas and turn down the inspiratory pressure and get one more blood gas in about a half hour. Okay. We didn't have N-tidal or TransQ. That worked well. Maybe you have that experience as well. However, the tidal volume was 20 mLs per kilo. Okay? And so we went up on the PEEP by 1, and the compliance improved drastically, so much in pressure that the tidal volumes became excessive, right? So the pressure required to inflate that lung, we didn't need much because it was almost linear, almost to the point where it's now hyperinflated. Absolutely, that lung is hyperinflated. If you look at those diaphragms and that tidal volume. So are we protecting the lung in this case? No. But what's even more concerning than that, and this is something for new RTs, maybe you realize this, maybe you don't, but there's fairly new kind of emphasis, there's been this paradigm shift in respiratory therapy management of newborns, that we need to focus on the CO2 as much as we need to focus on the lungs. Because in essence, what happens when you look at these post-mortem slides, and I do have graphic slides, so I apologize. I know I made some of you guys cringe earlier, but hey, whatever it takes, right? And so in this slide right here, we show a brain slice of a kid whose CO2 was way too low for too long. So in the cerebral vessels of newborns, especially in preemies, they respond to hypocarbia by constricting. So when you choke off the blood flow to the brain, you don't get good O2 carrying capacity, and you get ischemic changes in the brain. And so that's consistent with periventricular leukomalacia. So you see these cystic changes right here in the ventricles. And that's not normal. It's like scar tissue. And over here, if on the other end of the spectrum, if we have massive changes in CO2 as a result of patients becoming hypercarbic, or maybe they're hypercarbic and they become hypocarbic and then they become hypercarbic again because someone's messing with the ventilator, it's those big changes in cerebral blood flow velocity that may cause interventricular hemorrhaging. Two things that I think that respiratory therapists and physicians alike can potentially prevent by using ventilation strategies that are protective for the lung but also for the brain as well. And so I'm going to just briefly talk about Ryan's respiratory equation of motion. I think it's super important because every time I get called to a patient's room, and for 1 week every month I'm on call as a respiratory manager, and I love it because I can still enroll patients in research, but I also get to go to the bedside, and I get to talk to the respiratory therapist and find out what's going on. And 9 times out of 10, it's just we need more pressure, we need more pressure, we need more pressure. Or we need a suction, or we need to get the fluid off because their chest wall compliance is horrible. But basically what I'm trying to say here will predict the likelihood and success of implementing volume guarantee if you're only willing to accept higher pressures than what you've traditionally accepted in the past. Because if you do pressure control, you may not be able to ventilate that lung, because when you ventilate the lung, in order to get gas flow moving through it, you have to overcome resistive elements, and you have to overcome inelastic components of the lung as well. And so these things are in series. You've got the intrinsic airways of the patient, which may become edematous. You have bronchospasm, you get secretions in there, or the ET tube, which is small in relation to their native airway. But also keep in mind, if you have a leak in that endotracheal tube, you have to use higher pressures. And so this whole pressure thing, and barotrauma, we need to pay attention to what our pressures are doing, but we need to forget about pressure for just a little bit. And it's almost like you have to take duct tape and put it over the PIP for a little while and then just look at the trends occasionally. Because if you want volume-targeted ventilation to work, you have to realize that the airway pressure does not represent your alveolar pressure. I'm going to say it again. And for people who are still old school, no offense, I was there with you, but it's barotrauma because we couldn't measure tidal volume before. if you have a leaky ET tube and you got a 50% leak, you have to use a pressure of 30 in order to get a transpulmonary pressure of 15. Okay, so realize that if you got a leak and you got a distended abdomen and you have BPD, this does not represent the alveolar pressure. Because if you got a big old neck belly, then the pleural pressures are going to be high because that's part of your pleural pressure, part of your chest wall, right? And so your pleural pressures could be 20. I've measured them in those kids. And the only reason why we are able to use PIPs of 50 or 60 during VG in some of these kids is because we measured airway resistance, we did inspiratory holds, we looked at transpulmonary pressure, and we realized the baby's lungs are not seeing much of this at all. And so based on that, we use, fewer kids go to the oscillator, we're keeping more of them on VG. We trust that volume is what is gonna kind of tell us what the lung injury is gonna look like, because we started having kids with PIPs of 50, and wow, they didn't pop, and they got better in time, and everybody was cool with that, because they really trusted in that measurement, and especially when you're making that measurement at the airway. And so just keep that in mind, especially with BPD kids. They have high airway resistance. You do an inspiratory hold, which we don't typically do in babies because they breathe rapidly, but they also have leaks. But if you could get that pressure to equilibrate between the airway and the alveolus, then that would reflect your airway pressure. We've shown that airway pressures of 50 really maybe only result in kids that don't have distended abdomen or leaky tubes. Maybe you only get about 20 in the lung because all of that is kind of a pressure loss. It becomes attenuated across that high airway resistive element. And so keep that in mind. And that's the biggest struggle that we have in teaching this, and especially to some of my neonatology friends that have been doing this a long time. It's like, okay, guys, we're going to do VG now, but you're going to have to accept higher pressures. Because in volume guarantee, it adjusts the inspiratory pressure to try to match the tidal volume. And so I just really wanted to spend a little bit of time focusing on that for a minute, because that's the biggest limitation that I find. And if you choose a cutoff of peak inspiratory pressure, cool. Maybe you want to, in our CDH patient population, once they hit 26, surgery wants them all to go to the oscillator. Okay? And I'm like, okay, all right, fine, whatever. I mean, as long as we agree on something. But furthermore, I'm trying to make the case that pressure really doesn't reflect lung injury based on these animal studies. And so in rats, there was a seminal study that was published back in the late 80s by a group that basically went in and they used a high pressure, high volume strategy where they put a low pressure, high volume strategy where they take a chest cuirass, they put it around these rats, and the airway pressure was 0, right? So your atmospheric pressure was 0, but there was a negative pleural pressure pulling on the chest wall, creating a high volume. So that was case number 1. Then there was a high pressure, high volume group where they used excessive tidal volumes. Maybe that was 12 mLs per kilo and accepted PIPs above 30. And then there was another group that had their chest walls banded. So similar to some baby with sepsis that has anasarca, or some super edematous kid, or some kid with a big old abdomen. So if you think of that clinically, these subjects had this super high pressure, but the tidal volume was 5 mLs per kilo. And so what they showed, and you're not responsible at the end during the test that I'm going to administer to understand what any of this means, but when we look at extravascular lung water content, bloodless dry lung weight, albumin space, those were early indicators that there was significant injury and inflammation in the lungs. And so basically what that shows is that, with a chest cuirass, where you have low pressures, that's almost like a leak, kind of. Well, then your injury rates are so much higher. With a high pressure, high volume, your injury rates are so much higher. But the high pressure and the low volume, you barely have any injury at all. That's similar to like a control animal, maybe. And so we can't really rely on pressure always to inform us on lung injury. However, we can use it to trend. If a leak's getting bigger, the compliance is going down. But in pressure control, you can't use it for much, right? You can just look at tidal volumes to determine what's happened with your leak and with your compliance changes. So there's lots of things that can really impact the level of pressure, but it may not necessarily reflect excessive pressure delivery in the lung. So what do we know about lung injury? Well, in these animal studies that I keep talking about, we know that even with short-term ventilation with excessive tidal volumes of around 20 mLs per kilo, that can ignite the inflammatory process in the lungs. And when you do that, you get little rents and tears in your alveolar walls and in your capillaries are leaking. You can transmit those pro-inflammatory mediators systemically. and they can be sent to other organ systems. And that is a big reason why we may be kind of creating this multi-organ system failure or systemic inflammatory response system. So when you're ventilating the lungs, you're not just ventilating the lungs, you're ventilating the bloodstream, the brain, and all your organs. So keep that in mind. And it's our responsibility as respiratory therapists to do that and to do it well. And so when you're in the delivery room, I remember my first delivery that I went to. I wasn't pretty. I was getting yelled at because I was anxious and I had big hands and I was, my prefrontal cortex hadn't developed yet and I had high circulating levels of testosterone. And I literally, they're like, back down, just chill out, chill out. And I did, and I learned from that. And it only takes 6 breaths, really, to ignite this inflammatory response. So remember when that person went to go get takeout sushi and came back? That kid had already been ventilated with 10,000 breaths after that change in compliance occurred. But the alarms weren't set tight for the high tidal volume. The blood gas wasn't obtained until the kid, until the doctor came in and looked at the kid. So just keep in mind, it only takes a few breaths. That's it. And even if you hit your hammer 30,000, take a hammer and just whack your finger 30,000 times a day, it will become inflamed even though it doesn't hurt, right? So it's just that repetitive nature of ventilation that can cause injury and inflammation. Don't try that at home, please. So I talk about PEEP, insufficient PEEP, as being a primary mechanism for lung injury. And I think that's twofold, right? We know that when you're not using enough PEEP, you get atelectasis. And you have a higher FiO2 requirement because you have pulmonary shunt. So the high FiO2 is responsible for injury, but also these airways sticking together, creating that shear injury, which is definitely a problem. We know that all adds to injury and inflammation in the lung and puts them at risk for BPD. So if you're going to use tidal volumes of 5 to 6 mLs per kilo, whatever mode you're going to use, I would definitely suggest trying to use the appropriate PEEP as well. And so we'll talk about that in the management guidelines. But it's tough because we don't really know what the PEEP level is that we should be using, right? Is it based on blood gases? Is it based on cardiac output? Should we use chest radiographs to determine lung volume when that's such a poor index of end expiratory lung volume, and it's just usually an inspiratory film, and so it's tough because it's just one planar view. You're not looking at a cross-sectional area of the lung to understand what's truly going on. So with that being said, I'm just going to show you this right here. This is a preterm rabbit from Australia, and try to look at this like a kind of like a fluoroscopy image, where you see lighter. Light represents more ventilation, and dark represents dense lung tissue that's atelectatic. So this is in the first few minutes of life, and this is a rabbit that's being ventilated with a mask with 0 PEEP. And what we see here is that we overdistend the airways, but the distal lungs aren't really receiving much ventilation at all. But if they are, they collapse very quickly, right? So this is what happens when you're not using enough PEEP, because pressure goes to the area of least resistance. So it goes to the large airways. That's why we have tracheomalacia, right? Sometimes we don't use enough PEEP, and if you're ventilating relatively stiff alveoli, or lack thereof, through these compliant airways, you stretch them out. And you can create bronchomalacia, tracheomalacia. I mean, that's something that leads to this in time. Sometimes it's unavoidable. So the other thing that I would like to show you now is what happens if we just give a little bit of PEEP. And my friends Melissa and Stuart Hopper from Monash University are doing wonderful things with these images. What happens if you just use the same tidal volume, but you give 6 centimeters of water a PEEP? What happens? Well, you've completely changed the game now because there's more than one way to open the lung. You can't open a lung without providing expiratory pressure. You can't preserve the end expiratory lung volume unless you actually use some expiratory pressure. It's impossible in these kids. I mean, we do it with CPAP. Then why shouldn't we do it on the ventilator? People aren't afraid to use CPAP 8 or 10 in some of these kids that are failing. Then they go on the ventilator and they're all on 5 or 6. So it just seems a little backwards to me, right? Anyway, so you can understand now that when you go from this to that, you're going from 0 to 60, but if you're going from 30 to 60, there's less lung injury. So it's not just tidal volumes, it's pressures on, and we don't even really know the magnitude that PEEP and lung recruitment and high FiO2s have on lung injury, at least in preemie lambs. But I can tell you that it definitely contributes, and it's something that we need to kind of keep in mind. So what does lung injury look like under a microscope? And I don't have any true human subjects, but again, we're referring to preterm lambs, and these are control animals. And so they go in and they take a biopsy of their lung, and what they're looking at, don't look at FA132 and 136. Think of this as a 27-week preemie, and think of this as a term newborn, because their gestational length is a little different from ours. Within 3 days, it's almost like 3 months, or 3 weeks. And so if we look at the preterm lung, we don't have true alveoli. We've got these distal air spaces that kind of end in blind sacs, right? So we're in our cannulicular stage of lung development. And we see this huge interstitial space, and there's no real alveoli, because if this is the septal wall, then in time it's going to invaginate, and the body sends a message to basically thin that layer and have these little alveolar secondary crests bulge out into the airways. That's what holds the capillaries and increases the surface area. Those little alveolar crests will increase the surface area for gas exchange to occur. But by that same mechanism, we have an improvement in compliance. We may not have to use as high a ventilator settings or as high an FiO2 because we have the surface area for gas exchange to occur. But if we get in there and we start banging this lung and create injury and inflammation, this all stops. You don't get ongoing growth and development of the alveoli. You get alveolarization that is just halted, it's arrested, but also the pulmonary vessels don't develop. So you're dealing with basically one non-functional alveolus. Do you know what that's called? That's called BPD. So BPD really is pulmonary growth arrest and the arrest of pulmonary angiogenesis in the lungs, because we used too high an FiO2, there was injury, there was inflammation, we used too high of a tidal volume potentially, or we had atelectasis trauma. And so the lungs hate that. They don't grow when there's injury. And this confirms that right here. In the group out of University of Utah, Kurt Albertine and colleagues, even when you ventilate them with a relatively lung protective strategy, this is 3 days later, which is 30 days later for us. Look at the structure of the lungs. It hasn't changed at all. If you go back over here, they look more coalesced and stretched out, and and there may be more injury in there, but the interstitial space is still thick. There's low surface area for gas exchange to occur, and the terminal airways look about the same, right? However, if you support those subjects with non-invasive high-frequency ventilation or bubble CPAP or whatever your mode of choice is, in this case it was nasal high-frequency ventilation, then you can see at 30 days equivalent or 3 days from this right here that the lungs actually do grow, as long as you're not insulting them with all these high settings. And so anyway, your surface area for gas exchange improves. What you're seeing here, ladies and gentlemen, this is BPD. It doesn't look much different from day one. Okay? And so if you could look under a microscope, you'd see that you have a lot of non-functional alveoli, a lot of alveolar dead space, high physiologic dead space, all things that we struggle with to be able to ventilate these babies in the NICU. So how do we prevent this? This accounts for $25 billion a year in expenditures, and it is a tremendous strain on healthcare, on families. How do we prevent something like this from actually happening? Well, that's up to you. It really is, and I hope that you have physicians that support you and they respect and admire what you have to say at the bedside, but it's situations like this. How many of you are respiratory therapists? How many of you are doctors here? Do we have any doctors? Thank you for coming. Thank you. So there's your physician champion, right? Call a friend. No, I think that, it's when you come to things like these, you learn a lot and you come back and you're invigorated, and there's no reason why your docs aren't going to listen to what you have to say, especially if you have some evidence, and you have a recipe for this, which I'm going to give you today. And, you have a team that's willing to protect patients, and, I think that it's kind of a no-brainer, but it's really up to you guys. And I guess what I wanted to try to say with this slide, and I'm going the wrong, whoop. With this slide right here, this shows a baby born at 26 weeks. This is 1 month later. And about 2 weeks later after that, this kid was tracheotomized and on an astral ventilator and sat in the unit for almost a year. How many of those do you see? Yeah? Okay, so what if, I'm just going to propose this little scenario. Walk with me for a second. What if you spoke up in rounds one day and said, hey, the kid's FiO2 is 30, he's on volume guarantee and his PIPs are like 20 and his PEEP's at 5. What about if we extubate him to NIPPV or we go to CPAP or we do something like that? Just asking the question. Situational awareness, right? So you make this an issue like, hey, what if we try to extubate here? Or can we try this? That's what we started having our respiratory therapists do, speak up a little bit, and say, hey, ask why this kid who's relatively stable, why they need to be on a ventilator. It's interesting to hear. And if you don't have a weaning strategy in your unit, you should. You really should. Or you should at least be asking the question, because what you do right here predicts what's going to happen out here. And it doesn't matter if you have to reintubate the kid a couple of times. You have to be able to support the kid free of ventilators if you expect the lung to grow and you expect the injury and inflammation to subside in that kid's lungs. Otherwise, you get non-functional alveoli, and now you're on 15 a PEEP because you stretched out his airway and he's on 60%, and he's going to go home on that. And the family's deathly afraid of what the consequences may be if that tracheostomy falls out or the ventilator stops working. Or, so seriously, guys, I'm just painting a very kind of bleak picture for you because it's the truth. If we come in and we ask, can we get him off the ventilator, or can we get him out of pressure control and maybe put him on a lung protective strategy? What could that mean for this patient? Is it possible that even though they are injured in the course of, this clinical course, even though they're injured, doesn't mean you're going to keep them on a ventilator. You can still take them off, right? Because lungs grow. The lung alveolar units are going to grow up until about the age of 9 in number, and then size, and up until 19 or 20 or so, depending on the textbook that you're referencing. So what is lung protective ventilation? Lung protective ventilation is extubating your patient, putting them on non-invasive, or trying to support them non-invasively before putting them on a ventilator, right? And I think we're getting pretty good at that, but we want to try to mitigate lung injury by not intubating, by not putting them on the ventilator. But then some people like to protect the lung and use permissive hypercapnic strategies, and there's really not a ton of data out there to support doing that. And really, we don't know what the cutoff is before they start flooding their brain, once the CO2s go up and we put them at risk for IVH. So, most people will kind of be like, as long as the pH is greater than 7.25 and the PaCO2 is around 45 to 65, we've really lightened up on our parameters. And so what that means is instead of ventilating the lung 30,000 times a day, now we're ventilating the lung or cycling the lung 20,000 times a day. That might make a difference, less injury to insult, or less insult to injury. And so not only, again, is it lung protective, it's brain protective, and you're protecting the other organs as well, right? But that's difficult. It's very, very difficult to do this because we've got a layer cake. You saw the x-ray. Well, this is the CT scan of the same baby, right? And so we've got areas of atelectasis in the dependent sections of the lung, and then we've got these relatively healthy-looking lung units here. And so when we ventilate, we're ventilating this right here with 6 mLs per kilo, and we're exposing that to excessive tidal volume. But then down here where all the blood flow is, right? If most of the blood flow is, we've got a situation where the zone of the lung is experiencing a high VQ mismatch. And so if we're not using PEEP, then we're just going to injure the heck out of this now, and the lung injury is going to get worse, right? And so we want to protect this, but we want to recruit this lung as well and prevent the small airways from high-fiving one another. So what about if we use a tidal volume? We set a tidal volume and let the pressure take over. Let the pressure take over. We're still in pressure control, all right? You're going to get your variable flow. It's going to be comfortable. Not always, but most of the time it's going to be comfortable, but you're going to have a decelerating wave flow pattern and a square pressure waveform. Don't worry. You'll have high median wave pressure when it's needed the most. So why are people so resistant to using volume guarantee ventilation? It's a number of reasons, and a lot of it has to do with ventilator performance and their ability to do it, because when you think that you go to a conference hall, you think you're comparing apples to apples when it comes to volume guarantee or PRVC or whatever your tidal volume targeted mode may be. But you're simply not. They all behave very differently, and we'll talk about that a little bit today. And so why are people so resistant? Part of it has to do with the fact that when folks were using ventilation in the NICU, the earliest forms of ventilation sometimes were these volume cycle ventilators, the Bourne's LS-104, where they had a piston. You set the tidal volume at 50, or 25, I think was the minimum tidal volume, and they're literally ventilating these 1 kilo kids at 25 mLs per kilo. So you can imagine that the outcomes in these kids were not so good, and plus they didn't use PEEP, so that kind of is a problem as well. So really they abandoned this whole volume concept, and it makes some of the neonatologists and some of the respiratory therapists that were involved in this early on cringe. Very unwilling to we're kind of Luddites to a fault because we're not willing to accept this new technology. We have to trust the ventilators in what they say they're doing, especially if they've been validated and validated again and tested and your flow sensors are working appropriately. We have to be able to trust the ventilators. Even today, after the original meta-analysis was published, I think back in 2001, that showed that there are improved outcomes in babies supported with volume-targeted ventilation over pressure control. Only a very small portion of people in the United States actually use this mode of ventilation. In Canada, there's 81% of them using volume-targeted ventilation. In the US, it's 39%. That's why when I come into a room and I ask people, how many of you are using pressure, how many of you are using tidal volume, only about 50% or 40% of you raise your hand. And I think it's important to understand and discuss reasons why people aren't using that and identify those issues and kind of get to the bottom of it, because we should all feel pressure to make this change. One thing and I'm not bragging, I promise, but in the Northwest, 77% utilization, which is comforting to know because we really did a lot in that region to train people, having workshops and doing stuff like this to expose them to this new mode of ventilation. But none of it was easy, trust me. None of it was easy. There was a lot of sweat, there was a lot of blood, there was some skin flying and hair and a few other things in order to get us to at least follow these management guidelines. And so it does definitely take a lot of effort. And back in the Northeast, where I first kind of started practicing respiratory care with neonates, there was about a 32% utilization. So I hope that, with the improvements in ventilation performance and with the improved understanding of how ventilators contribute to lung injury and chronic lung disease, that we can now start to make this change. But keep in mind that there are differences in the modes of operation of these ventilators and how they deal with endotracheal tube leak. People fear dead space from flow sensors and resistance that's imposed. People realize now that you can't do this back at the ventilator very well. Let's be real, okay? There are companies that say you can, and I'm here to tell you that you can't. Because when you take that ventilator out of its package and you hook it up when it's dry and it hasn't been cycled 30,000 times a day for a week, then your compliance is very different from what it's going to be day to day. And now you've got it humidified. It wasn't humidified before because you don't want to break the circuit. Anyway, so you cannot do volume-targeted ventilation very well. You cannot trigger very well back at the ventilator. And I'm going to show you some slides. I got data. I wouldn't say that if I didn't have confidence in my ability to support my statements with some research. How is that, Natalie? So ventilator nomenclature, we talk about the different modes. We don't even know what to call these. Is it volume guarantee? Is it volume targeted? Should it be volume limited ventilation? It sure as heck isn't volume cycle ventilation, right? Or, it's not like what is being used in the adults. However, a lot of the early studies were done in babies with an adult fixed flow volume targeted mode of ventilation with the Bird VIP. We know that there's going to be breath-to-breath variability in an infant's respiratory rate. They breathe all over the place, right? Sometimes they don't breathe. And so we need to know how well these ventilators are working. And we know that the improvements in ventilation, we can't emphasize that enough, have ushered in this whole new group of microprocessor ventilators that are able to control tidal volumes. So volume guarantee is pressure control, right? But it's like, I tell people it's more like cruise control in your car. You're going up a hill. You set that at 40 miles an hour. I set it at 80 in Seattle because we live fast and we're pale white and we drink a lot of coffee. But when you're going up a hill, the accelerator now increases, right? And that's what this does. It increases the PIP to provide a consistent tidal volume target, much like your cruise control. And then you go down the other side of the hill. And you think about, the proverbial mountain that babies have to climb when they come into the NICU, and you get to the other side. Pressures now start weaning, but my accelerator backs off to maintain the same pressure. So same thing, and it's usually breath by breath, but unlike volume, you get the fixed flow, but you set a minimum tidal volume. Some ventilators have the ability to limit excessive tidal volume delivery, and when that volume exceeds 150% or 125% of what's set, then it will terminate the breath for you. So it's nice, because these algorithms take a little time to kind of get the baby to where they need to be, right? And I don't know about babies here in Nashville, but in Seattle, man, they get a little anxious over there, and you have to go in and with calm words and stroking, you can usually get them to where they need to be, and it's tough because these babies are not really liking mechanical ventilation, as sensitive as they may be. So the way that it really works is breath by breath, the ventilator will wean the inspiratory pressure based on a tidal volume that's either being measured at the flow sensor or back at the ventilator. So if that tidal volume becomes excessive, which it is here, then it starts to drop the pressure by 1 or 3 centimeters of water pressure. Each ventilator is a little bit different. And I don't really try to focus on one ventilator in particular, but I just happen to have about 60 of these ventilators in my unit, so I have a lot of graphics. And so in the ventilator we use, we set the Pmax setting, and then the ventilator will dump once it's 5 above that Pmax setting. And we've really gotten pretty good at trying to set that about maybe 10 to 15 above what they're currently ventilating at. But then if they have a leak, we need to go much higher. If they have BPD, we need to go much higher. But anyway, the ventilator will dump the breath as it has right here. Maybe, actually, we didn't reach the pressure in this one, but what it's done is it's weaned the pressure down a little bit. So in the background, maybe we met that excessive tidal volume that's set at 150 of this, 150% of that. So that's why we had such a drastic drop in the pressure, because the gain is a little bit different. You're going to have a higher drop in pressure. But also in these modes of ventilation nowadays, there's separate algorithms going on all of the time, different algorithms for when the baby's not breathing versus when the baby's breathing, and it tracks their respiratory, what the tidal volume is during spontaneous breathing, and has a different VG measurement in assist control if they're triggering versus not triggering. And so that dual algorithm makes it more comfortable for the baby, but it makes it also so that you're not providing excessive pressures, because during a spontaneously triggered breath, you're generating a pleural pressure, but you don't want to be at the PIP they were at when they weren't triggering a breath. So it backs it down based on what the previous spontaneous breath was. So it's kind of cool. It's kind of slick. And again, the way that we set up our screens is a little bit different. I'm going to talk about that here in just a minute. But anytime you have somebody who says, well, I don't believe I can accomplish just by sitting outside at the nurse's station playing cards, I can accomplish exactly what you can. Okay, an ace is an ace. And I can accomplish exactly what you can, but I'll just go in there and I got an alarm and I got a volume limit. So I'm just going to keep them in pressure control. And then, this happened a lot when we implemented volume guarantee because it was unfamiliar. People resist change. And so basically I went in and I said, all right, well, let's go back and look at the trends. And let's look at your apneas and Brady's. And the kid was on a low rate. Let's look at your periodic breathing. And that kid was bing-bonging all night. The nurse said, I couldn't play cards at all last night because that kid was just bing-bonging to the end. And I think it's because the RT took him out. And I'm like, yeah, let's put him back in. And then I took the RT and I said, look, your volumes were all over the place. Did you even calibrate the flow sensor during your shift? And we have our night shift RTs are some of the best in the world, but they got that way because they've really kind of gotten good at ventilating these babies and following all of our different protocols. And so we've got like playing cards now that have all the different VG algorithms on there. So if you look at this slide right here, this is very telling. These are babies over 24 hours that were born prematurely, and multiple babies were included in this study. And it's more of a descriptive study where babies were supported between pressure control and the other group was randomized to receive volume guarantee. And if we look at pressure on this axis and we look at volume on this axis, and we're constantly monitoring these things over 24 hours, and you look at these little box whisker plots, if you see kind of this tight configuration and the whiskers are smaller, that means there's not a lot of variability. This is your median or your mean if it's normally distributed. And so this is your pressure. So the pressure doesn't change much in pressure control, right? It's the volumes that are all over the place, right? And that's based on changes in mechanics and rate, effort, all over the place. So what does that mean? Well, our tidal volumes went down to maybe 2, down to even 4 mLs per kilo, but then went up to about 8. What does that mean for the baby's brain and for their lungs? You kind of see where I'm going with this? And then people worry, well, the pressures were all over the place. They went up, they came down. Okay, but what about the tidal volume? Okay, now we realize why we're not getting as many blood gases in this mode as well. Just take the UAC out and maybe see how this kid does without all of that. So a more consistent tidal volume in time means that you're more lung protective and you're more neuroprotective when you use a volume targeted mode of ventilation. But again, you got to have higher PIPs. Because in the case of pressure control, if you have an endotracheal tube leak, the only thing that pressure control is really great at is if your tube migrates down to a main stem, it will limit tidal volume delivery, right? And of course, your kid's going to get sick, but that's the big thing with pressure control, and you have to be careful with volume guarantee. In pressure control, if you develop an endotracheal tube leak, your x-ray will look like that eventually. And so in our institution, we had a lot of our, nurses and nurse practitioners and physicians that didn't want to upsize the tube. And I don't remember the last time we've upsized the tube. now that we have a ventilator that can correct for that leak. But in the past, what would traditionally happen is if you develop a leak, your tidal volume going in is going to increase and your expiratory tidal volume is going to go down because for that same PIP, if you get a 30 or 40 or 50% leak, half of that is being blown out to mom and dad as a kiss in the room, right? So you're not getting that pressure. So what do the lungs want to do? They want to close down, or the baby increases their respiratory effort. So there are a number of ventilators now, and most of them will do this. Some of them do it better than others, but there are a number of ventilators that will adjust the inspiratory pressure in volume guarantee. When you set a tidal volume, and I don't have the settings on here, let's say we set it at 5. The ventilator is going to give 10.5. The expiratory tidal volume is going to be 2.5. How can that be? Don't even put those on your ventilator. Put the absolute volume that it thinks it's delivering. So in this particular ventilator that we use at our institution, it's going to target a theoretic tidal volume based on a leak calculation. So we always think of leak compensation on exhalation, but in this case, leak compensation is occurring during inhalation as well. Because if you take your PIP, you take your PEEP, you take your inspiratory time, your expiratory time, and you look at the leak flow that you're losing, take all of that and put it into an algorithm, the ventilator will adjust the pressure based on what it thinks it's giving the baby. And this can work up to about an 80% leak. So this is an 88% leak. I didn't believe it, and I'm not someone who willingly embraces new technology. So, of course, we take things into our lab, and we want to evaluate how it all works. But in theory, if you have a ventilator that's able to correct the leak, you're going to have higher pressures, right? So your pressures may go from 20 in pressure control to pressures of 26 because it's looking at inspiratory and expiratory tidal volumes. It's looking at inspiratory leak and expiratory leak. Not all ventilators do that, only a few. Those are the ones we've had most success with. So what that means is if you develop a leak, instead of having the tidal volume go down to 7 mLs, it's going to stay at 10, right? But it has to use a higher pressure. It's just physics. So then the lung looks like it's open a little bit more. So that's one of the benefits of volume-targeted ventilation, but only if you can leak correct and you can leak compensate. And so if we look at the majority of I'm not here to like dazzle you with any specific mode or breath type, but I think it's, I'm here as a messenger. Don't throw tomatoes at me. But I don't know what ventilators you use. I just know what I've tested, and I know what we've used in the animal lab, and I know that many of these ventilators perform differently when you have an endotracheal tube leak. It probably doesn't matter as much if you don't have leaks, but I know in Seattle we got a lot of wide necks, and we just use smaller ET tubes, and we do have significant leak to the end that we couldn't do volume-targeted ventilation effectively before. And so I'm just going to briefly go over how the ventilators that are widely used in the marketplace right now perform. And so with the Draeger, the CareFusion, and the Servo-I, how many of you are using the Draeger VN? Okay, quite a few. And CareFusion, Avia, couple. And then Mackay Servo-I. You using it in your NICU? Okay, you'll find this a little interesting then. It's an animal study, but nonetheless. And so, brace yourself, I'm sorry. I know you're gonna throw a tomato at me. So these modes, essentially, the rep is going to come in, and these guys back there with the sandwich boxes, they might tell you, hey, this is going to support all your kids. You're going to get the tidal volume you need. We do volume targeted better than anybody else. I'm the guy that comes in there and says, well, prove it. Because I have to talk to the RTs because they, for some odd reason, put a little value in what I have to say. But I need a little money first, and so people chip in a little money. In these modes, they're very, very different. Because we use proximal flow sensors with the Draeger and the Avia. They're heated hot wire flow sensors, pain in the butt, right? I've got some things that could help you with cleaning them. I think they've gotten a lot better, and I think the heated ones are the best way to go because they keep the schmutz off them pretty well. Well, with the Draeger, it uses inspiratory and expiratory leak at the proximal airway to determine what the inspiratory pressure is based on this theoretic tidal volume. That's the one I showed in the last slide. Now, the CareFusion uses expiratory tidal volume to guide peak inspiratory pressure and lung inflation. So what it's looking at is exhaled volume. So there's a tendency sometimes to maybe overshoot the tidal volume, hence the reason why we have a 4 to 6 ml per kilo tidal volume range. Because the majority of the studies that came out early on using the Baby Log 8000 Plus, which is essentially the mode within the Avia, was based on expiratory tidal volume. So we thought we were getting 4 to 6, but in reality we're probably getting 5 to 7. So I'd tell you, I'd probably use 5 to 7 in that case. And so keep in mind that both of these have proximal airway flow sensors, so you trigger at the airway. This one has a leak compensation algorithm which upon exhalation, It preserves the PEEP when it's activated, but it also adds additional flow to make sure that you're able to trigger effectively. So less likelihood of auto-cycling the ventilator. And with the Mackay Servo I, widely used NICU, I see it all over the place. And I actually was a huge servo supporter with the 300 for years. I thought that was a wonderful little ventilator. But with PRVC, and we tested this in the assist control mode, you can use a proximal flow sensor. It's disposable. But that proximal flow sensor doesn't allow triggering or any input to go back to the ventilator to adjust your cruise control. And so, furthermore, it uses inspiratory tidal volume that's measured back at the ventilator. So inspiratory tidal volume, what does that mean for a kid that has a leak? Do you think the pressure is going to go down or up? Down, thank you. Because if you have a leak, it's going to see this big inspiratory volume going in to maintain that pressure because you're adding more flow to maintain pressure throughout the I time. And it's going to say, oh, that volume looks pretty big. I'm going to start weaning the pressures. And so my friends call me all the time, like, how come I can't do PRVC very well in the NICU with these kids with a leak? I'm like, well, if they don't have a leak, you're probably fine, but let's test it. Let's test it, find out what's going on. And so we took it in a lung model, and this is about a 50% leak at 20 centimeters of water pressure. And we set the tidal volume at around 6 mLs, so super small, like 1 kilo baby, in an ASL 5000 test lung. And what we showed is that the ventilators that actually have some leak correction factor, whether it's exhale tidal volume or it is a leak compensated algorithm based on inspiratory and expiratory tidal volume, they showed that you can really kind of get to the volume. And there was the PRVC mode, it definitely weaned down with this leak condition. But what does that mean clinically? I don't know. I don't really know. But I think that a lot of people will kind of stick to using pressure control with that ventilator, and it's a wonderful ventilator. I like their graphics more than a lot of the other ones. But when it comes to PEEP, none of the ventilators really do an excellent job. Again, this is a static lung model. It's got a fixed leak. The Servo I, because it doesn't have a leak compensation algorithm on exhalation, is not able to provide the PEEP, at least with the I. But I think with the new N and U, it's really changed a lot, and it's a nice little, pardon the slide, but this is the trachea of a rabbit. The rabbit was made to be surfactant deficient, similar to a very, very sick preemie with RDS. And so this trachea is being tied off after intubation with a piece of umbilical tape, or like an umbilical string that you put around the umbilical cord. And so what we do is we test each of these 3 ventilators and evaluate the performance based on the measurements we're acquiring with an esophageal balloon catheter. And we're finding out what their respiratory effort is, what their gas exchange is. And so we're looking at work of breathing and all of those things without a leak. And then we loosen it up so that we implement an ET tube leak at 20 centimeters of water pressure. And it's pretty interesting what kind of happens because each of the animals are supported with all of these different ventilators with identical settings. And what I think is pretty interesting is that this thing doesn't work. And if you look at the peak inspiratory pressures on the upper line over there, you can observe that the pressures are generally kind of within the range that we need to have, but the Mackay was a little bit higher, right? Because you're adjusting pressure based on your tubing compliance factor back at the ventilator valve. So that has a tendency sometimes to kind of overshoot or undershoot the tidal volume. But in this case, without the endotracheal tube leak, it wasn't horrible. It was only off by about 4%. And the respiratory rates were all similar. If you look at these pressures after you implement an endotracheal tube leak, this is pretty fascinating. The pressures go up with the Avia because it's basing its adjustment and pressure on a leak. And if we see here with the Draeger VN, it's adjusting its pressure based on a leak. But here with the Mackay Servo I, the pressures are actually being weaned down, okay, based on that inspiratory volume. And really, this is helpful for any ventilator manufacturer, right, to show that it's really probably not an awesome thing for them, especially if they have an ET tube leak. You want that picture? The paper is published in Respiratory Care Journal this month, so I can send it to you as well if you want. PaO2. There was no differences in oxygenation between the different groups and with the different leak conditions. So not a big deal. And these animals were breathing spontaneously, but what I find interesting is that the CO2 levels were a little bit higher with the Servo I, 70-ish, and a little bit lower with the other ventilators, but not statistically significant. No difference really there. It's only when we implemented the endotracheal tube leak and the pressures actually increased in the 2 groups that had leak compensation where the CO2s were significantly lower. And that may not look like a big clinical difference, but I can tell you that the work of breathing went way down. I'm like, what the heck is going on here? And their PIPs went up to about 28 or so. But in the Servo I, it did not. and the CO2 had actually stayed high. I'll tell you in a minute why their CO2s were high with that ventilator. If we look at pH, and I think that this is pretty forthcoming, with no leak and an endotracheal tube leak, especially in the two ventilators that adjust based on that leak, if you look at the pH, that is significantly different. That's a big deal. That's like 7.30, that's 7.24. Okay? Who would have thought that an endotracheal tube leak would have been beneficial in eliminating some of the CO2 rebreathing? I think of this like high flow nasal cannula, which I'm going to speak on later, where you're literally flushing and rinsing the anatomic dead space by providing a little bit more pressure so that when they breathe back in, or when they exhale, they're not rebreathing that CO2. So it kind of, I think it rinses the dead space a little bit, and that's part of the reason why we saw higher pHs, but only in the ventilators that adjust based on a leak detection algorithm. So in the Servo-I group, I think part of the reason why the CO2s were high is because you're triggering way back at a ventilator. So these subjects were sedated, but I've seen this in babies as well. You try to make it as sensitive as possible, but they're triggering 4 feet away and they've got thumb-sized lungs and an accordion in between. And you can't always reliably detect sensitive efforts being made by babies through that much distance and that much kind of real estate. And so even when we had a leak, it actually helped a little bit. It kind of eliminated the signal to noise ratio a little bit, or probably put them at a more preferable state to be able to flow trigger. But in the case of no endotracheal tube leak, they were generating 2 breaths sometimes. That's the pleural pressure, the esophageal pressure. They were generating 2 breaths in order to get 1. And so if you have NAVA, that's cool. Maybe they can trigger a little bit better. But I think with this new ventilator, things are going to be a little bit different for them. But this just kind of speaks to kind of older technology and kind of newer technology. I know that a lot of the ventilators are going down the same route by incorporating proximal flow sensors and using leak algorithms. This is work of breathing. So we take the esophageal pressure change, the effort, we multiply that by respiratory rate, and what we get is pressure rate product here. And you can see with the leak, the work of breathing was much lower. And I think that's because we were getting more pressure, but we were flushing the CO2 out, at least with the 2 ventilators that were able to do leak-corrected tidal volume delivery, whereas with the Servo-I, it kind of stayed the same. So I think it kind of speaks a little bit to how different ventilators perform, and you may not think that those are major clinical differences and that they don't really represent any significant changes, but for those of you that maybe have tried to use these ventilators with leaky tubes, or maybe you'll understand a little bit better why, and manufacturing will be guided better on how to design modes of the future. And so the last part that we want to kind of touch on right now is how to manage kids on these mechanical ventilators. How do we manage them appropriately? Well, we know that the pressure is going to wean and the tidal volume stays constant as the compliance goes up and as the resistance goes down, and with patient effort as well. This is probably the most important slide that you'll see if you're thinking about trying to initiate this in your units. And please keep in mind that out of these 12 randomized controlled trials and almost 1,000 infants with respiratory distress syndrome that were enrolled between and outcomes were compared between pressure control and volume targeted ventilation. Most of the modes that they were being supported by were older ventilator modes like the Babylog 8000 Plus and that with the VG, and also the VIP Bird with basically a fixed flow volume cycled mode of ventilation, or volume control rather is what I was trying to say. And so, but regardless of the technology, and I'm sure that the technology is better now today, if we were to kind of repeat a study, no one's going to support that. And furthermore, I don't think there's enough, equipoise to do something like that, because we think that this is probably the right thing to do anyway. So who would want to enroll their kid in a study with pressure control if the outcomes may be worse, right? So what they demonstrated out of these 1,000 babies is that if you look at all the data and you put the prospective randomized control trials together, they showed that the length of ventilation, the rate of air leak and pneumothorax, the incidence of hypocarbia, the need for blood gases is another one, but also the incidence of IVH, grade 3 or 4, and the combined outcome of death or BPD, at 36 weeks was lower with volume targeted ventilation. And so that, I think, tells a pretty compelling story on reasons why we should do this, but I'm not going to go through every one of those outcomes and discuss all the different studies, because I want to teach you guys how to use this better. And I think that's what the last few minutes are going to be devoted to. And so there are many different modes. The breath type is really volume guarantee. Volume guarantee is not really a mode. It's an adaptive pressure breath type, right? And the mode that you use it with could be assist control. And I think with some ventilators, they make it really confusing and they put a bunch of acronyms in there. And it's like, well, are they in pressure control or are they in VG? So I think that we should just tape this up, tape that up, tape this up, right? Amen. I know, I don't know where that came from, but I have provided feedback an input on ways to do it a little bit better, but what's done is done. So what this means is that every breath is volume targeted, regardless of whether the patient's taking a breath or not. So every breath, you're going to get consistent tidal volume. But that also means that every breath is weanable. SIMV, not every breath is weanable because you're setting two breath types, confusing. RTs don't get it, doctors don't get it. Like, well, look at the tidal volumes right there, they're too big. That's not a volume guarantee breath. That is a pressure support breath. What do you mean? And I'm like, just eliminate this. Use that for BPD kids that are getting sweaty and withdrawing and are hyperinflated. That's what we do. So every baby that comes into the NICU, 90% of them are supported with ACVG. You're asking, well, why wouldn't you use PSVVG? That's the optimal mode because we've seen PSVVG result in 0.2 or less I times, and then the kid's now going up on the PEEP and their FiO2 is going up and no one knows why. Because their mean airway pressure is like super low, right? And we had one kid go on an oscillator because of that. And so we don't use it at all. We just make sure that the respiratory therapists are super good at setting the inspiratory time. And so based on my friend Ryan's presentation, what are we saying here about this I time? It's too long, right? Yeah. So we try to train the RTs on becoming experts at airway graphics. You have to be in order to use this. And so, so basically we stick to this, we reserve this for our BPD kids, and then we don't ever use this here. But that's us. And we do things a little bit differently. And so why do we use AC? There are now several publications out there, and some of these were a little, you know, there were short-term physiologic studies that actually looked at the differences between AC and SIMV using a volume-targeted mode, and they showed that, yeah, you get more consistent tidal volume delivery. Oh, really? Yeah, that's cool. That makes sense. Well, you know, there's maybe more work of breathing with SIMV. I'm like, oh, did you measure it? No, it's just kind of based on some retractions and some subjective measures and high respiratory rates. And then there's a randomized control trial, again, showing consistent tidal volume delivery. But really, there's one study out there, and I apologize, I'm going to add that reference a little bit later, but it's relatively new. And this is a study in preterm babies that evaluated work of breathing between those supported, and we're going to forget about this because we don't use CMV anymore, but let's focus on SIMV and AC, both supported in volume guarantee mode, and these are the different tidal volume targets right here. I don't know a ton of people that are using 4 mLs per kilo because at 4 mLs per kilo, the work of breathing is higher than at 5 or 6 because you're getting less pressure, all right? And so if we look at 5 or 6 mLs per kilo, which is still within our reported range that we use, between SIMV, 242 for the work of breathing measurement, that's pressure rate product, and 200 almost doubles when you're in SIMV compared to assist control. We don't know on those pressure supported breaths what the tidal volume is or if we're even using enough support or if it's confusing the baby. I know that I have an airway graphic that shows what you would think is a VG breath, but it's really a pressure support breath, and the VG is weaned down to 0, and it's confusing. They're like, that's pressure support, and that's the mandatory breath right there. I'm like, nope, it's the other way around, because they're weaned, and they're ready to come off. So how do you know that they're ready to come off? If the pressure has not been removed from the airway and they're not doing well, you know, or the pressure has been removed and they're not doing well, then that's obviously an issue. But if they still have a bunch of support and you set that pressure support at 10, how do you know they're ready to be extubated at that point? So I'm going to kind of focus on tidal volume delivery. Do we know what the appropriate tidal volume is that needs to be set? Well, based on some of these animal studies and based on human studies, we know that 3 mLs per kilo results in more lung injury than 5 mLs per kilo. And so we need to avoid that with caution. These are some of the volume dosages here. And so I'm going to send you guys all off with all of this. Based on these volume dosages, you can see that the tidal volume target's a little bit higher with the smaller babies to overcome instrumental dead space. So the super small babies may need a slightly higher tidal volume target. So what happens? Do we set that tidal volume and do we forget that tidal volume? No. You remember Ron Popeil, you set it and forget it? Remember the rotisserie oven? Well, that's not the case with tidal volume. In time, babies' airways stretch out and we have increased anatomic dead space. And they're trying to tell you something when their CO2s are going up at 30 days. I'm getting BPD, but also the set tidal volume hasn't been changed in 30 days. And because of that, I'm going to breathe above it. That's the major reason why PIPs wean and you get that runaway PIP phenomena. And so this is what that looks like. In VG, it's just doing what it's supposed to, right? Compliance gets better, my effort's there, my FiO2's down. So if you have a kid that's in assist control, they're really not in assist control any longer. They are in CPAP. So the question is, do we need to wean them? Oh no, let's put them in SIMV. For what? You know, if they don't look good, let's go up on their PEEP a little bit, or maybe even go up on their tidal volume a little bit. The ventilator's doing what it's supposed to do. And then I get this nurse that calls me, DeBlasi, you need to come up here because your ventilator's not doing what it's supposed to do. And I'm like, well, that's only when you're in the room. You were there, you know, and then you changed the diaper, and then you fed the baby, and then, you know, you changed the diaper again, and then you were in there mucking around, who knows what. And she's like, oh. And I'm like, because the PIP's weaned, the kid, you know, got a little anxious and wasn't getting the support he needed. But when you left the room, he was fine because his tidal volumes went back to normal and his PIPs went up again. I would rather have that than some mode of ventilation that's going to increase the level of support based on the patient's effort. You can do the math on that. So here's a kid right here that has relatively stable lungs. The PIP is low. They're basically on CPAP. Lungs look great. What do you do? That's right. And so that's what we do typically. But in the kid that doesn't look so well, and they got punky looking x-ray, air bronchograms, they're tachypnic, and you know, they have pressure that's weaned. Do we put them in pressure control? No. We go in and we look at their weight, and we update that weight every week. In this case, that baby's weight was set inappropriately. And since we set tidal volume as a dosage, the RT, we may have forgotten to, you know, update that tidal volume target based on their weight, right? So the mLs per kilo didn't change, but the tidal volume did because we updated the weight. But now, since we went up on the tidal volume and that kid was not yet ready to be extubated, the PIP's higher and the kid looks great. Maybe there's another way to do that. What's another way to increase your PIP and volume guarantee without increasing the tidal volume or updating the weight? PEEP. You can increase the PEEP as well, and that will actually help with lung inflation. So this is one of those kids that was on a low tidal volume. It wasn't the appropriate tidal volume for them, and of course the PIP's weaned, and he was stressed and was kind of breathing a little bit hard. And so we went back and revisited, and we're like, oh, I think we set the inappropriate tidal volume. They went up by like half an ml or 1 ml per kilo, and you can see now that the baby looks more comfortable in that case. So in our testing with rabbits, we actually show that with even small changes in tidal volume, that really affects the distribution of tidal volume delivery to the lung. So we look here in the back portion with this electrical impedance tomography device. It's basically a non-invasive CT scan that you can do. And it's just for research purposes right now, but you can see that the CO2 goes up when the tidal volume is 6 mLs per kilo, and there's less ventilation going on. But if we just increase the tidal volume by 1 ml per kilo, we can see that the CO2 improves, the respiratory rate comes down, the PIPs go up, and there's more support. So that's what we actually suggest in these kids when we're supporting them. Other studies in human infants, preterm babies, and term newborns alike, when you increase the tidal volume, you reduce the work of breathing. So don't be afraid to kind of go at the higher end of that tidal volume limit. But also in BPD, we have to be able to adapt and use higher tidal volumes than what we have traditionally used because of the anatomic dead space. So you may have to use 10 or even 12 mLs per kilo in that case. So keep that in mind as well. So this is one kid who responded favorably to actually going up on the PEEP. We went up on the tidal volume and we went up on the PEEP as well, but you have to look at what your FiO2 is, what your saturations are, and what the x-ray obviously looks like. And so this is a kid that we weren't afraid to go up on 8 or even maybe 10 of PEEP. And in my final slides, I'm gonna leave all of you with this. And a lot of what I've spoken on with this volume targeted ventilation has led up to this management strategy that we've developed. And so we have playing cards for this. You can develop little kind of laminated plastic cards if you want. Basically what this says is these are the initial settings based on weight and or disease state. This is CDH, which we have kind of a different protocol for that. However, we start here. These are the I times, these are the tidal volume targets with BPD. With mild BPD, we evaluate every week when a patient who may become hyperinflated or may have higher CO2s, higher serum bicarbs, maybe we need to increase their tidal volume based on what their PIP is and what their work of breathing, as well as other things. And so we don't know what the exact time for us to do that is, but we do know that these are the few babies that if they are supported in assist control, we may need to go to SIMV if they show signs of hyperinflation. And so we're using that low tidal volume, long I time, higher PIP setting. So then we have a low PIP algorithm where if their PIP's low, is it transient or is it continuous? Go back and look at your trends. And if their PIP is actually low and they don't look so good based on this, then we have a way to mitigate the issue of no pressure and no support by increasing the tidal volume target or increasing the PEEP or both. And then lastly, if they look good and they have acceptable gas exchange, rather than going into SIMV, we'll just extubate right from there if their PIPs are within a reasonable range. And so, we only put kids into pressure control if we absolutely have to. And usually those are the HIE kids or some surgical kid that, they want to keep on a ventilator, but their PIPs are too low and they don't want to collapse the lung. So Anyway, I've got slides right here that magnify or explode these features of our protocol. It works well. We've changed it so many times. And we used to have little booklets, but they wanted a one-pager, you know, so that we have these hanging everywhere. The RTs have all of these. I'm going to share these with you guys as well. And basically, this is kind of the caveat. When you got a baby that comes into the unit, they go onto ACVG. There's no question. They go onto ACVG, and these are the initial settings. And then, you know, there's some other little pearls down here and in the way that we manage them. There's the low-pressure algorithm I just talked about for those of you that would like a photograph. But I am going to send this to you all. The high PIP algorithm is a little bit different. We get lots of surgical kids in there, so if we need to use higher PIPs to do volume guarantee, we will do it. If they have leaky endotracheal tubes, we will use higher PIPs rather than upsize their tube. And so this is our higher PIP algorithm, which basically broken down shows, you know, issues with hyperinflation. Again, when they're hyperinflated, we switch them out of ACVG and we go to SIMV. They do look a little bit better, and especially since, you know, they're on high support, high PIPs. If you're in AC and you're agitated and you're scared and, you know, whatever, then you're more likely to kind of have more spells or become hyperinflated and have high dead space issues. So going to SIMV is better because if you get anxious, you get smaller breaths potentially. And so we do kind of stick by that. And we're not afraid, again, to use these higher pressure settings. So thank you very much. I know that was a lot of information, but one thing I do have to say is, as respiratory therapists and that one amazing neonatologist that's sitting, or physician that's sitting in the back of the room, it's really up to you guys to determine how to address neonatal lung protective ventilation in your unit. Take my protocol, use it. If your baby's a different here, cool, change it. I'll give you, or tell me and I'll change it on there for you and I'll send you a new flow diagram. I think it's important that, you know, that we're all doing the same thing, not necessarily the right thing, because we don't know what the right thing to do is. So if you just focus on a standard process in place and you support 80% of the babies this way, then in time you'll maybe start to see better outcomes. But you got to use your brain as well, and you got to actually look at the baby and understand when they're trying to tell you something based on graphics. Because as you can see, the success of volume guarantee really relies very heavily upon the use of graphics and excellent clinical assessment, which I know you all have. Thank you.